Good morning, everyone. Thank you so much for joining us today for a discussion about the state of the COVID pandemic in Massachusetts. I'm Anna Kuchman, the Medical and Biotechnology Editor at the Boston Globe. Joining us today are Michael Curry, President and Chief Executive Officer of the Massachusetts League of Community Health Centers, and Dr. Jacob Lemieux, Instructor of Medicine at Mass General Hospital and Harvard Medical School, and an expert on infectious diseases. Thank you so much to both of you for taking the time to join us today. I wanted to just mention to our audience that you may submit your questions throughout this call by using the Q&A button on the bottom of your screen and submitting them that way. So thank you again so much to both of you for taking the time to be with us. Dr. Lemieux, I wanted to start with you. Could you maybe start us off by talking a little bit about the state of the Omicron surge in Massachusetts right now?
Sure. Well, thanks for the invitation to be here, and thanks for organizing this event. I'm really glad that we're getting a chance to answer readers' questions and talk about the state of the pandemic. I think in order to talk about where we are now, we kind of have to go back to where we were just before Omicron wave started. And, I think we were all looking forward to the first Thanksgiving where we could take off our masks and see our families and friends and have kind of a more normal Thanksgiving. And there were a few signs that that was within reach, but a few kind of warning signs. There was a second surge that was just starting in the late fall, early winter, and it was particularly severe in the upper Midwest and in the Northeast. And then out of nowhere, I mean, almost completely out of the blue, came the most transmissible and the most immune evasive mutant form of SARS-CoV-2 that we kind of imagined. And I think it was far more transmissible and was far more adept at evading immune responses than people would have guessed that a mutant or a variant of SARS-CoV-2 might be. And then in basically 30 days flat, what we now call the Omicron variant has swept across the globe, causing tens of millions of infections. It's become the dominant variant in just about every country on the planet, first in South Africa, but then within a few weeks, pretty much every other country, including the US. And is now causing on the order of 800,000 infections a day in the United States. So we are in a very difficult time, quite honestly, in the pandemic, and we've learned a lot in an incredibly short amount of time. We know that this is the most transmissible variant that we've ever seen. But there are a few silver linings, and one of them is that it seems to be less severe. In some cases, that's because people are better protected. They've been vaccinated, but inherently, as a property of the virus, it seems to cause less severe disease, less commonly causing pneumonia, more of an upper respiratory picture. And the other silver linings are that some, but not all of our treatments still work. And nearly all of the approved vaccine platforms work quite well, particularly against preventing outcomes like death and hospitalization. And the vaccines work even better when they've been boosted. Finally, we're starting to see some signs just today, just this week, that we may be at the peak of the Omicron wave, especially where it came first, places in the upper Midwest and the Northeast. And there's some signs that it may begin to recede just as quickly as it came on. So I'm actually optimistic that there is a light at the end of the tunnel, but over the next few weeks, there's going to be a lot of cases in the region, and unfortunately, a lot of hospitalization, and unfortunately, some of those patients are going to become really sick or even die.
And Michael, I wanted to bring you into the conversation here. We've done a lot of reporting on the toll that this surge has taken on the healthcare system. And I wondered if you could share, from your perspective, how is this hitting the community health clinics that you work with?
And I join Dr. Lemieux. One, thank you, Anna, for this conversation. Thank the Boston Globe for convening it. I think these are critical and timely conversations. And I probably start by recognizing folks like Dr. Lemieux. I was in an airport about a year ago, and I was sitting waiting for a flight during the pandemic. And some medical providers walked off the flight, and folks just started clapping and applauding like they do for the military. And it was a reminder of that these folks were probably going to a hot spot to provide support at a hospital. And they were acknowledging that they were risking their lives at a point in the pandemic where people didn't know how infectious this disease was, or whether they would have the right PPE to protect themselves, or what it looked like in that facility. So I just want to acknowledge, take a pause with all the hospitalization, death, and infection, just to remember that this has awakened us to the importance of our healthcare workers on the front line. So thank you, Dr. Lemieux, for that. I think the critical part, 51 health centers across the state. We serve over 1 million patients out of over 300 practice sites. We often say we're the canaries in the coal mine, way before the pandemic. You want to know what's going on with diabetes, heart disease, cancer, health inequity in communities of color, immigrant communities, poor communities, rural communities. We were on the front line of that work. Now, what we saw was when this pandemic hit, is all those things were exacerbated. We saw people deferring care, right? They couldn't come in as they normally would to get their immunizations, and their diabetes, their heart disease, their cancer, and other treatments that they needed. So we're trying to solve for that now, right? We've spent the last year trying to get people back into care, which was deferred to deal with that crisis. That's just one major challenge, Anna. But then we're also in the throes of doing testing, and we know testing, Dr. Lemieux, is critical. We need to be able to test you, notify you that you've tested positive or negative, so that you can make the right decisions about returning to work, to school, or whether you need to quarantine in your household. And timing of that testing is so critical. So we're in the throes of that now. And then balancing those two with the issue of vaccinations, that we need to still push these vaccines into communities, into households, that we know, Dr. Lemieux, that this saves lives. And we know that there's a hesitancy for a reason, but we at the health centers have really been on the front lines of dispelling some myths that the people have gotten online, of speaking to the efficacy and safety of these vaccines. And that's hard work, because we've not always been trustworthy as a healthcare system. But that work is ongoing, and it is pretty extreme, trying to do all these things and get vaccines and now boosters in the arms. And then last but not least, as Dr. Lemieux knows, we have therapeutics, right? You have monoclonal antibodies, remdesivir on the hospital side, Molnupiravir, and all these other medical advancements that are now coming online that can also prevent severe illness and death. And we're now in the throes of figuring out what our capacity is with workforce crisis that all of us are dealing with doctors, nurses, and other medical staff that have tested positive and are now quarantining or sick. As well as staff who have been exposed and may have tested positive themselves and may have to quarantine. So it's a lot to juggle, Anna, but I have the same optimism that Dr. Lemieux does, that we're getting a handle on this, that this Omicron spread, quite frankly, does not appear to be as deadly and severe. I saw a data point, Dr. Lemieux, that I thought was striking. It said between middle of December to middle of January, 3 billion people will contract this disease, over 40% of the world's population. I don't know how accurate that is, but it seems anecdotally from our own personal relationships and our coworkers, staggering the spread of this disease. But Anna, I think, there's a lot to do, and burnout is really serious in the health center space as well as the hospital space and other settings. We're trying to do a lot to manage all these different challenges.
Mm-hmm. Thank you so much. Yeah, you got at sort of the next question that I wanted to ask, which is that I have seen those estimates that more than 50% of the European population and possibly more than half of the American population will eventually end up getting Omicron. And I'm wondering, Jacob, is that what we can expect here in Massachusetts as well?
It's a great question. It's so hard to know because the tests that are recorded it's not a perfect measure of the true number of cases for two reasons. One, we've never captured everybody with testing who's been sick. And two, more people are using at-home tests, and those tests aren't easily counted. And I don't want to say that, I don't want to sound like that's a bad thing. That's a great thing. People are using at-home tests. They're using that information to keep themselves safe and their families safe. So I think this is just the nature of the passage actually from a pandemic state of mind to kind of a more normal state of mind, that we are going to lose count. And I think that's okay. We will, of course, need to keep count of the severe cases. We'll, of course, need to understand the pressures on the healthcare system and numbers of hospitalizations and ICU beds and all of that. But in terms of knowing what percentage of the population or even keeping track of this over time, I don't think we'll ever have great data, certainly not in the moment. There are ways to track that by looking at antibody responses to see who got infected. But those ballpark numbers sound pretty reasonable. Omicron is among the most transmissible pathogens that we've ever seen on this planet. So, and if you look at something that was circulating in one or a few countries in the early part of November, middle of November, is now everywhere, and the dominant strain everywhere. So absolutely, it's going to infect lots of people. Fortunately, most of those cases will be mild, especially among people who are vaccinated, among people who have access to treatment and are able to get care when they need it. It's still causing a lot of death and destruction, and I don't want to minimize that, but it's also causing a lot of widespread infection. And as a result, accelerating the transition to endemicity. And I'm sure somebody is going to ask, what does it mean to be endemic? Are we getting there? So it's probably a good time. Let me just kind of give a few comments there. Endemic is where we're headed. Endemic means that there's an equilibrium between the pathogen and the immunity in the population, such that on average, the number of cases that emerge are also cleared at an equivalent rate. So there's an equilibrium. And it's an equilibrium between pathogen spread and population immunity. An epidemic is the opposite of having endemic, meaning the case counts are increasing. Now, influenza, for example, RSV, other viruses, they're endemic, but they also have seasonal epidemics. So it doesn't mean that cases are going to be flat forever, but there's not going to be major changes beyond what we would typically see on a seasonal basis. Obviously, given what's happened with Omicron over the last 6 weeks, we're not there yet. SARS-CoV-2 is not yet endemic. There's still a pandemic. But what Omicron has left in its wake, along with vaccination, is a ton of immunity. And as a result, that immunity, which is a lot easier and safer to acquire by vaccination, but a naturally acquired or convalescent immunity will also do it too, will likely accelerate the transition to endemicity. When SARS-CoV-2 will be endemic, I think we can't say, but someone said, referring to the comment, it's darkest before dawn. And I do think that we may be in a place like that where things look really bad right now, and they are really bad, but the Omicron wave will be over. The new medicines are increasingly available. We have supply-demand mismatch right now, so that's a consideration for people's behaviors. But there's a lot of immunity out there. We have vaccines that work. We increasingly have medicines that work. And I do think we're on the cusp. I can't say exactly when, but I think of transitioning to a better place. And I think on this point, the last thing I want to say is just this final comment that we have an epidemic of, and we have a pandemic of SARS-CoV-2. We have horrible pressure on the hospital system, patients all around the world. But we also have been doing this for 2 years now. We have an epidemic of loneliness. We have an epidemic of misery. We have an epidemic of despair. And we are social creatures, and we all want to see our family, friends, our loved ones. And so I think we need to be clear about communicating to people that we will not be in this place forever, that there is a light at the end of the tunnel. And even though it feels like we've never been further from that with all the cases, I actually think we've never been closer to that.
Thank you so much. So there are several questions from readers kind of along those lines. If maybe the majority of the population will get Omicron eventually, we have a question from Jane asking, does it make sense to just try to get sick now with Omicron and get it over with? And if you do catch Omicron, what does that do to your immunity? Does that, set you up for even better protection, for the next variant or for the remainder of the pandemic?
Yeah, so I'll take this one on immunity. So this is what your immune system was kind of built for. It was designed to learn over time with recurrent exposures and get better. But there is also an arms race between pathogens and your immune response. So pathogens mutate, your immune response gets better over time the more exposures that it has. And so we're still learning exactly how the effects change and how convalescent immunity adds to vaccine-acquired immunity, and there are some subtleties there. It does seem that natural immunity provides, in some sense, some measurable parameters, longer lasting and stronger responses, but the combinations of vaccine doses and the combinations of vaccine doses plus if people are unlucky enough to get natural infection, all those things together do appear to induce strong protection against, in particular, severe disease and hospitalization. That doesn't mean that people are going to be immune from infection. Vaccination, natural immunity, it's not a force field. So people are still going to get infected, but by and large, the vaccine-induced immunity plus minus convalescent immunity do strongly protect people from severe disease. And when you add on top of that a less virulent virus, and you add on top of that effective medications that are widely available, and that's the last piece where we're not there yet, but you start to layer these defenses, and I think we can get back to more normal.
Great. Turning to Michael, or I really wanted to ask both of you, what specific actions would you like to see the Baker administration take during this surge and kind of going forward with COVID?
So, one, credit to Massachusetts, right? Massachusetts is in a better position than much of the rest of the country because we've been responsive. It's because we've had people have a seat at the table, right? Having community advocates have a seat at the table. That's what led to the Boston Black COVID Coalition working with the state and the city around creating a site at Reggie Lewis Center, or the work that was done in Chelsea with the Latino advocates and East Boston Health Center. We've learned some valuable lessons in this pandemic, and I think Dr. Lemieux would agree, which is if we always focused on partnerships, we could have solved major issues years ago. But this pandemic forced us to come across our sort of sectors and in our invisible divisions, hospitals, health centers, nursing homes, city, state, and federal, to explore different strategies on how to address this. That being said, we need to do more of that, right? As we try to get kids vaccinated, and there's some challenges around getting kids who are diverse vaccinated, similar to what we experienced with getting adults vaccinated. Some of that is the hesitancy of the parents. Some of that is access issues around vaccinations. So can we get it into schools? I know, my children go to school in Brockton. Got a robocall just this week saying, hey, there's testing at our schools. Make sure you get your kids tested. So we need to have all those strategies. Two is we need to remember, and I think this was inherent in Dr. Lemieux's comments too, we're in a pandemic. And I know as much as we want to open up and be back to normal, we're not there yet. And the reality is, I think the number now, and I was just looking at it, 63 million people infected across the country. since the outbreak of this pandemic. And I want this number to sit for a second. 840,000 deaths, over 840,000 deaths. I think we sort of gloss over that. We need to remember that that's more than the population of the city of Boston. So if you imagine if everybody in Dorchester, Roxbury, Mattapan, Hyde Park, East Boston just dropped dead right now, that would be the scale plus of what this pandemic has really caused us across this country and frankly thinking globally across the world. So we have to take that in and be really serious about mitigation strategies, still wearing a mask. And I know it's hard for even me sometimes as I'm moving about to be conscious and vigilant about wearing the mask. Social distancing where we can. We need to still be embracing vaccines and solving for those who may not be willing to take the vaccine. Or now the booster, because I know folks who took the vaccine, Moderna, Pfizer, J&J, who are now hesitant about the other shot and the booster shot. So I put that on us, Dr. Lemieux, that their hesitancy is our problem, not theirs. That we ultimately, if you're African-American and you know about J. Marion Sims' experimentation on slaves or Henrietta Lacks or Tuskegee syphilis, or you don't know any of that history, but you've been sort of passed down in generations not to trust them systems. Or if you've had your own lived experiences with our healthcare system that tells you can't trust it. Whatever the reason, we got to solve for it. We need to reach you where you are, speak to you in the language and the cultural competence that will convince you that this is about saving your life. And most of those that are in our hospital ERs, as Dr. Lemieux knows, or who are impacted in a disastrous way, in a severe illness way and death by this disease is increasingly those who are not vaccinated. So we need to do that work and be vigilant. So I think, Anna, that's where we need to go. And then data, last but not least, we don't have good data. And I work pretty closely with John Snow Incorporated. There's a group of us, Black and Latinx healthcare leaders, Dr. Lemieux, that have come together, leading systems. Kevin Churchwell at Children's Hospital, and Tom Sequist, and Elsie Tavares at Mass General Brigham's, and Juan LaPera at B.I. Leahy, and so many others. Black and Latinx leaders come together to try to deal with this issue that existed way before COVID-19 of health inequity, and how we use this opportunity to identify those closest to the disease were always Roxbury, Mattapan, Worcester, Springfield, with 2+ comorbidities, with poor environmental conditions, dealing with racism, with systemic issues that made them more unable to not live in a congested household because of their housing, or made them more susceptible. And there are frontline workers, so they couldn't remote access in. So we're trying to solve for all of that. And I think this group coming together, working with Secretary Sutters, who's been extremely responsive to me and to the health centers, as well as Governor Baker, government needs to continue to partner and be open to criticism and be open to strategy that's coming from the people actually impacted by this disease. And I think we're headed in that direction. And again, we're ahead of much of the rest of the country.
Thanks so much. Jacob, do you have anything you want to add to that around, policies that you'd like to see from the state?
Well, I just would echo everything that Michael said. I mean, it was a really, I think, unfortunately, all too accurate and beautifully stated description of the impact and the failings in response to the pandemic, and how it's exposed so much of the injustice that exists in society. So I would just echo what I thought were really insightful comments. I would also add to that I think we need to criticize. Leaders need to be open to criticism. At the same time, we have to recognize that nobody has a crystal ball. I think if you would have polled people 2 months ago and said, how likely is it that yet another variant is going to emerge, and this one's going to be way more transmissible and also way better to get around the vaccines that have worked so well. If you polled 1,000 scientists, how likely do people think that is? I would bet nobody would have predicted that. And in that short amount of time, 6 weeks later, here we are. This variant has spread across the globe. It's completely changed the planet in so many ways. And all of all of the people who are in positions of leadership, they're just trying to adjust to the data and the new reality in the way that all of us are. And so I think recognizing that good leadership has many qualities, and being open to criticism is a key part of it. But at the same time, even our government officials, our leading scientists, our leading community organizers, there's only so much they can do in the face of a natural disaster that has been unfolding for 2 years and is incredibly unpredictable. And so I think as much as we can to try to bring civility to the discourse, and just recognize that things aren't going to go perfectly, but being open to criticism, being critical but also respectful, and having a dialogue is going to be one of the ways that helps us get out of this, and also do better next time and learn the lessons that have been painfully learned in this pandemic.
And Anna, one other quick point. I chaired the Health Equity Task Force for the legislature with Dr. Seau from Cambridge Health Alliance and many other really brilliant leaders across Massachusetts. And one other critical point that I wanted to lift up is our public health systems in our cities and towns across the state. I'd be remiss if I didn't mention that quite frankly, historically here in Massachusetts and across the country, we underfunded public health. So folks were operating with not enough staff, with not enough resources. So when the pandemic hit, they weren't able to respond and lean in the way that we needed them to. If we don't learn that lesson, and credit to the state legislature for how they used the $4 billion in ARPA money to invest in those things, right? To invest in health equity to some degree, to invest in the work of our public cities and towns or across the Commonwealth, our public health infrastructure. We have to seize the moment, as I'm a Latin student, a carpe diem, seize the opportunity to invest in our local public health infrastructure. We'll be here again. There'll be another pandemic. We'll need PPE. We'll need ventilators. We'll need a crisis standards of care and an equitable version of that. And we'll need to make sure we have the workforce to respond to it. And we'll need a public health infrastructure that's ready, willing, and able to lean in the way we need to. So that's all policy.
Let me turn back to some audience questions. We're getting a lot of good ones. So there are a lot of questions around how contagious Omicron is and how you can catch it. I think last time there was sort of real guidance on this was sort of with our first variant, where you learned that 15 minutes of close contact with someone who was infected with COVID, that's what it would take to catch it. But, in contrast to that, how can we understand how contagious Omicron is? Can you catch it on the street if you're walking behind someone who has it? Can you catch it if you go into the grocery store and you're wearing a mask? What about if you walk into an elevator that's empty, but someone with Omicron, was in the elevator a few minutes before you? Is there any way, Jacob, that you could kind of try to flesh some of these out for us?
I can do my best. And I think those are great questions, and everybody is wondering these same things. And I don't have all the answers. In fact, I myself wonder these very same things when I walk into an elevator. Could there be some Omicron in here? And so, and that's been one of the hardest things about this pandemic. And I think this is one of the things that we've done wrong as a scientific community. There have been statements like, it's not airborne. Very early on, there were statements like, oh, it's something that you transmit from coughing and sneezing. And you do transmit it. You can transmit it from coughing and sneezing. But actually, we had a lot to learn about the way that respiratory viruses are transmitted. And there's a spectrum of droplets that can hang in the air and droplets that are transmitted by coughing and sneezing. And we lost a lot of opportunities to caution people and to limit transmission early on. So we've learned a lot, but we actually still don't fully understand. And that's frustrating. I think it's frustrating for everyone, for the general public, for scientists. But we still need to make decisions about how to act and how to try to limit our risk, even in the face of this uncertainty. So there are some things that we know quite well at this point. This is an this is a virus that transmits through the air predominantly. That is coughing, sneezing, as well as small respiratory droplets that stay suspended in the air. So masking works. The better the mask, the better it's going to work. So a cloth mask is better than nothing. Surgical mask is better than a cloth mask. If you have a higher quality mask like an N95 or a KN95, that's going to provide an additional layer of protection, as would a double surgical mask, for example. We don't really understand the extent to which fomite transmission or transmission on surfaces contributes to spread. But I think the general consensus, and this hasn't really been extremely well studied in a large number of studies, is that the vast majority of transmission occurs by either large respiratory droplets, coughing, sneezing, or small droplets, the so-called airborne route. So the primary things that we recommend are, of course, vaccination and boosting to keep you safe if you do get COVID, but masking, social distancing, and then an increasing focus on ventilation. So if you're going to be gathering, try to open the windows. I know it's winter, but to wear masks when you're in an enclosed space with other people. And then building on that, because it's all about ventilation and density and airflow, the outdoors is the safest place to be. And there are a large number of studies that are showing, or that have shown throughout the pandemic, that transmission in out-of-doors settings, particularly when there isn't high density, is extremely rare, to the point that it could almost be ignored. So I think feel safe when you're out of doors and away from other people. If you're out of doors in a big crowd, I think there is some risk. The biggest risk is indoors, and the biggest risk is indoors in high density settings where there's a lot of airborne generation of particles. So talking, shouting, singing, those kinds of activities indoors in poorly ventilated places are going to be the highest risk for transmission.
And Anna, Dr. Lemieux said something I thought I wanted to chime in on that I think is critical, and it's been a frustration of mine since the outbreak of this pandemic, which is the science is evolving. Our understanding of this disease is evolving. And I think people want concrete answers in the moment. And quite frankly, I agree with Dr. Lemieux that even not just social media, even in sort of the profession, people put out conflicting information. Right now, and it's question in your chat, was the question about PCR versus antigen, right? Do you need a PCR test or do you need an antigen test? And credit to Secretary Sutters in the state, we reached out, and I'm sure many others did, and said we need to be clear about which test you need, because when you crowd the PCR testing approach, which many are, right, because they need to go back to work or school, is creating this timeline issue where people can't get their test result in a timely way. So an antigen test, and Dr. we appreciate if you chimed in on this, in terms of infectiousness, is what we need to push people more towards. Get the antigen test, figure out if you're positive there, then you can make decisions around whether you can go back to work or school or whether you need to isolate. But right now, testing is really stressing the system. And then there's disparities. I know I had COVID just before Christmas, like so many other people did, between the middle and the end of December. And what I found of my own is I tested positive on PCR and negative on antigen. So I had to reach out to people like Dr. Lemieux and say, what is that? Explain that to me. How can I be positive in one and negative on the other? And I just want to tee that up for Dr. Lemieux, that we need to answer questions. And then when we don't know the answer, which I so appreciate about Dr. Lemieux compared to so many others, to say we don't know yet, and we're still trying to figure it out.
Yeah, there have been a lot of questions about testing and whether the rapid at-home tests work or not. And it seems like they work maybe slightly differently for vaccinated people who present symptoms much earlier before their viral load has escalated. I know the FDA has reported that some of the at-home tests have been a little bit less sensitive for Omicron than others. But Dr. Lemieux, what would you recommend in terms of how to use tests right now and how effective the at-home ones are for Omicron?
These are, thank you. These are great questions. I'm glad we're getting a chance to talk about this. confusing for everybody, including for those of us involved in creating tests and giving tests, using them, which is now everybody in society. So I think I want to take a step back and say one of the messaging points that I think can, has been important, but probably doesn't capture all of the tools in the toolkit is that we've been saying that vaccination is going to be the way that we're going to get ourselves out of this pandemic. And to some extent, that's true. Vaccination is one of the ways that we're going to get ourselves out of this pandemic. And being vaccinated is by far and away the simplest thing, and most effective thing that you can do to get to keep yourself safe. And if you're eligible to get boosted, that is, along with the primary series, one of the most effective things, or the most effective thing that you can do to keep yourself and your loved ones safe. But it is not the only tool in the toolkit. And on its own, it's kind of like a one-legged stool. And I think the other tools in the toolkit are testing and using the things that we have learned about how this virus spreads, and practical public health policies like masking and distancing and smart policy that we can bring to keep the maximum number of people safe, while also restarting society and getting people back to their normal lives and back to the things that make them happy. So with that, clearly, the biggest issue with testing, I think, is an access issue. We just need more tests. I think everyone agrees we need more tests, and the tests need to be more available, and they need to cost less, or ideally be free. Now, getting there is really tough. I mean, like, I can't even get one centrifuge for my lab delivered in 6 months because of global supply chain issues. There are so many things that are challenging about manufacturing and distributing billions of tests to an ever-evolving virus, that this is not going to be something where someone can snap their fingers and all of a sudden tests are going to appear. Now, there's a lot of progress being made. I do think there were some probably mistakes in planning and manufacturing that are lessons that we can learn from. But I think going forward, having access to testing is the critical thing. Now, PCR testing versus antigen testing. I think we're rapidly going to be in a situation where PCR testing is like the thing that your doctor does. And antigen testing is the thing that you do at home, that you pick up at the drugstore. And by and large, it's not perfect, but it'll capture, do you have a high burden of a virus in your nasopharynx, in your nose, and are you therefore quite infectious? Now, that being said, it's still early days. We're still learning things. One of the things we're learning is that Omicron is more of an upper respiratory virus. It doesn't like the lung so much. It likes the nose and the back of the nose and the throat. So testing may have kind of shifting kinetics. We may pick things up in different anatomic sites at different times. Maybe it's better to test saliva. Maybe the time frame of maximal test positivity is shifted a little bit. Early data suggests that may in fact be partly true. But also, the tests do seem to work well against Omicron, similarly to the way that they've worked against previous variants, both the PCR tests and the antigen tests, but we're still learning how to use them optimally, and we still have major access issues. So I agree with all the points. I also agree with everyone that it's really confusing, and I'm just optimistic, though, that these tests will be more available to you and your loved ones and help make decisions about when it's safe after you've been exposed or infected to re-engage in society.
All right, can you just summarize, I mean, when and how should people use the at-home rapid antigen tests?
I don't know, from a policy perspective, I can't give an answer because that depends on lots of considerations that I think are more nuanced than then can be given in a format like this. But I can tell you how we use them in my family. If someone has symptoms, we use one, and that is the first order of the first analysis. If someone has symptoms, we use one, and then we can guide our actions based on that. In the event that it's positive, then person and family would be asked to kind of isolate, and then there would be medical care sought. If it's negative, that doesn't mean that the symptoms aren't due to COVID-19. There still needs to be, I think, a definitive medical evaluation that involves typically a PCR test. The other way that we're using them is if there's going to be a gathering, if the grandparents are going to be in town or we're going to see relatives or something, we would ask everyone to take a rapid test just before seeing one another, so that if anybody turns out to be positive and would therefore likely be infectious, we can call things off, kind of in a game time decision. So I think those are two ways that they're potentially useful. This is limited by availability. So there's not a ton of these. They're quite expensive. And I think we need to figure out best how to use them on an individual level, on a societal level, make them more available, make them cheaper or even free. And it may be that people need to take not just one, but two, because there can be a window period where somebody who is truly infected, is not yet infectious, is falsely reassured by a negative test, then goes to an event, could be infectious. So we need to be really mindful of timing alongside these access and availability issues.
And Anna, just for some numbers, the governor did a press conference this week, and if your viewers did not have a chance to see that, the state is securing 26 million rapid tests over the next 3 months from iHealth. The Biden administration is also deploying rapid tests so that we'll have those. Cities and towns will have access to it. The Baker administration of those rapid tests will prioritize K through 12 education and childcare. And the message that Dr. Mew spoke to, but others have been lifting up in community health center spaces, that these tests are convenient, they're efficient, and they're, for the most part, accurate. So we need to use them. So I think it is all correct. Just take a quick second to acknowledge healthcare workers across the state. Again, health center staff have deployed, received 1.19 million vaccine doses and put 983,000 doses in the arms, administered that. And 65% of our patients that we put those in arms are people of color. So we talk about high rates of infection, hospitalization, death among Black, Brown, and other communities. We are on the front lines of doing that work. So I just want to acknowledge when they're burnt out, stressed, feeling like they're stuck in the throes of this pandemic, the tremendous amount of sacrifice in their service we need to recognize. I just want to take this opportunity to say that.
And yeah, thank you. And I just want to add to that. I think doctors, of course, we appreciate the recognition, but actually, in many ways, we have a relatively easy job compared to frontline staff, and the people who are day in, day out, like bagging groceries, working at the checkout counter. They're essential workers too. The nurses, the patient care assistants. So it's an incredible heroic effort across society. We would be in such a worse position if not for all the sacrifice and effort that everybody has put into this. And I just also want to acknowledge the suffering, the loneliness, the isolation, the despair that the last 2 years have brought, and to tell people that we will get out of this. We will have a more normal existence again. It won't be exactly the same. There'll be some things that are a little bit different, some things that we've learned, but this pandemic is not going to last forever. Omicron is not going to last forever. We are going to get to a place where case counts are more manageable, where we're not constantly reacting, where medicines are widely available, and people can engage in the things that they want to do and make them happy again. But we are not there yet. We still need to flatten the curve. We still have a tremendous pressure on the healthcare system, and so I would ask everyone to be patient for a little bit longer as we get out of this wave, and I think we'll be that much safer for it. So thanks so much, everyone. It's really a pleasure to participate.
Thank you so much, Jacob. Michael, do you have any other closing thoughts that you'd like to add?
The only thing is, I think we want to just again try to focus on partnerships, the health equity piece. If we do not seize the opportunity in this pandemic to address the fact that many Black and brown citizens across the Commonwealth and across the country never make it to 75. So we were debating who gets the vaccines and what the prioritization was, and I was on the governor's working group. What we were looking at was the fact that if we pushed 75 plus, and we did, but we moved quickly to 65 plus and two plus comorbidities, health center across the state, many of our patients don't live to 75 or past 75. So we need to center equity, Anna, and as Dr. Lemieux knows, in everything we do. Every time we sit down and have a conversation about some stage, some crisis, part of this crisis, we need to say, okay, what's the equitable way to do it? And we went through this with vaccines, whether you push J&J only to Black, brown, poor, immigrant, rural communities, that would have never been equitable. That everybody should have access to Pfizer, Moderna, and J&J. We knew that getting masks distributed was critical, and getting masks that protect you, KN95, N95, surgical, into communities, into people's hands that don't have the resources is critical. And as Dr. Lemieux pointed to, with trauma, we're experiencing extreme trauma in our communities. There's no way you can't deal with your mortality for the last 2 years. The fact that you could wake up tomorrow and you can't breathe, and then be in a hospital and not even have time to say goodbye to a loved one. We need to deal with the trauma that will carry on for years after this pandemic. So I'm very optimistic. You had me on with the right person, with Dr. Lemieux, because he makes me feel optimistic. I don't always feel that way, but it's good to be on with him, because I think there's a light at the end of the tunnel. And if we do what Dr. Lemieux and many others have been advising us, I think we'll be great.
Thank you so much. So Michael Curry, President and Chief Executive Officer of the Massachusetts League of Community Health Centers, and Dr. Jacob Lemieux of Mass General and Harvard Medical School. Thank you so much for joining us. To our audience, thank you so much. If you missed any part of this and would like to hear it back, we'll send a recording to everyone who registered today. Thank you so much for joining us.